Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1946, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and from around the world. Please note that the opinions and ideas shared on this podcast are those of the speakers and not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it should not be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice.
Well, hello, everybody. This is Dr. Kurt Rifleman with the Ogden Surgical Medical Society. I'm the CME chair for the society, and today I have the opportunity to help host this podcast. I'm a family physician in Ogden, Utah. And joining me today is Dr. Val Johnson. Dr. Johnson, do you want to introduce yourself?
I'm Val Johnson. I am very old. I've been around a long time, and I'm a retired pathologist. And I'm historian for the Ogden Surgical Society. And so I like to participate in anything we are doing. Thank you.
Great. Dr. Johnson's been a wonderful mentor for many of us up here in Ogden for many years. So I'm very happy to host with Dr. Johnson. Today we have a great guest. Dr. Shelley Lawrence is visiting with us, and I'm just going to do a brief introduction and we'll turn the time over to her. Dr. Lawrence is an associate professor of pediatrics in the Division of Neonatology at the University of Utah. Following her fellowship training, she dedicated the first 6 years of her career to a high acuity private practice neonatology group before then transitioning back into academic medicine at the University of Oklahoma in 2010. She received her Master of Science degree in Clinical and Translational Medicine in 2013 and relocated to UCSD for several years. Her research interests focus on understanding the fundamental mechanisms of bacterial pathogenesis, the neonatal innate immune system. She also designs and conducts multi-center clinical studies with the primary goal of translating innovative therapeutics and diagnostics from the bench to the bedside. She has active NIH-funded research to validate new technology by Melio Labs in the rapid and low-cost detection and identification of pathogens, including bacterial, fungal, and viral, in a single low-volume patient sample. She's also collaborating with Celix Therapeutics to investigate the use of host cell membrane-wrapped nanoparticles as a novel adjunctive therapeutic for neonatal sepsis. She has also contributed several book chapters in leading neonatal textbooks, including Remington and Klein's Infectious Diseases of the Fetus and Newborn Infant, Fetal and Neonatal Physiology, and also Neonatology Questions and Controversies. Dr. Lawrence, we are thrilled to have you today on our podcast. Thanks for coming.
Oh, yeah, it's a great pleasure to be here. Thank you.
You bet. Well, our topic today is to discuss syphilis, and in particular congenital syphilis, and the rise that has been seen in the United States. And maybe you could begin about just giving us an overview of what's happening with syphilis in the United States, and maybe narrowing that down to Utah also.
Sure. So we started about 10 years ago to notice cases in the United States were beginning to rise. And we noticed that rise particularly in the southern states of the United States. And then that rise started to slowly creep north to the northern states to where about 5 years ago, 6 years ago, we started to notice that the change in the incidence was starting to increase more in the West as the southern states started to initiate protocols and guidelines to help address their rise. It started then to creep into the West, that right now the Western states are the ones that are primarily affected, including those that surround Utah. The top 5 states, we have 3 that surrounds us, including Nevada, Arizona, and New Mexico, and the cases of congenital syphilis and the incidents. The other states that make up that list then is going to be South Dakota, and Texas still has some high numbers, but the West is where we really worry about congenital syphilis cases right now. When I first came to Utah from UCSD in 2021, I reached out to the state health department and Nikki Bear, who we've become very close, and we've kind of formed this syphilis task force that includes the state health department and then doctors in maternal fetal medicine, neonatology, and pediatric and adult infectious diseases. So through this collaboration, we've been able to identify protocols and guidelines that we could initiate to help catch pregnant women and newborns that are either at risk for syphilis or that have syphilis, so that we could start addressing and prohibiting that rise in the state of Utah. So when I first got here in 2021, Nikki Barr is like, Shelley, there's not a problem here. We've had a couple of cases from those that immigrated from other areas, but we haven't seen that our population as a whole has been affected. And I will say that Utah still remains like 47th, 48 in the nation for syphilis cases, with a good reporting system in place at the state level. But we did start seeing a rise a couple of years ago. And then that's where we started to be able to really affect change with these protocols and guidelines that we started to put in place. So even before ACOG came out and recommended 3-point testing in pregnancy, being the first appointment, first trimester, then again around 28 weeks, and then again at delivery, we were already working with our major healthcare systems, including Intermountain and the university, to try to get those testing guidelines into practice even before they were recommended by ACOG. And
Great.
that's been pretty successful.
Wonderful. So when did the ACOG and CDC recommendation come out for the triple testing in pregnancy?
Yeah, that came out about a year ago.
About a year.
Yeah, about a year ago.
Would you just take a moment and describe that? Because perhaps a lot of our clinicians are not familiar with that.
Yeah, so because of the rise, so I think the numbers are important. So in the United States, over the last 10 years, there's been a 10-fold increase in cases of congenital syphilis. In mothers of reproductive age, that being 15 to 44 years of age, there's been about an 800% rise in primary and secondary syphilis cases. Now, primary and secondary syphilis cases are still considered the first couple of years after infection, and they're the most contagious and transmittable stages of the infection. So as we saw the mothers rise, increase, we also saw then the babies were being affected and congenital syphilis cases rose. So because of that, ACOG came out and said we needed to test more often in hopes that we could capture more women that were getting infected during pregnancy so that they could be treated during their pregnancy, and hopefully then the babies would not be born with congenital syphilis. So the recommendation, again, is to do it in the earliest trimester of their first appointment, hopefully within that first trimester of pregnancy. But then again, to repeat that testing at 28 weeks or during the second trimester. And then the recommendation is no baby should go home from a hospital without having the mother retested at delivery. Through Intermountain and the university, we are using, there's 2 different ways to test for syphilis. There's the traditional pathway that most people are familiar with that uses the RPR or the VDRL test. That is an indirect way to test for syphilis. We test for the body host immune response to being infected with that organism. But there's also a reverse algorithm that has testing that can test specifically for the Treponema pallidum bacterium, which is the cause of syphilis. It tests for the IgM, IgG antibodies. And so with that testing, we are including both types during pregnancy because they work slightly differently.
Okay. So I struggle a little bit, and I have over the past several years tried to learn why we do the reverse testing instead of the traditional. But to me, it seems like it boils down to the cost of testing has changed, perhaps, and automation has changed. Is that correct?
Well, it has to do with some of that, but more importantly, it has to do with the way that the tests work. So with the RPR, as we discussed, it's kind of the host body immune response to being infected with Treponema pallidum. So it's an indirect measure of infection. So when a body gets infected with syphilis, then the cell membranes, our host cell membranes, get inflamed and it releases cardiolipin, a protein that's within those cell walls. That's what the serology on an RPR test for, is whether or not we're reacting to the cardiolipin in our cells. So that's where we get the titer too. We can do a serology-based dilution to where we can see then when that reaction is no longer happening. So then we can even get an idea of kind of like the response our body is having to syphilis infection. That test, unfortunately, many things can complicate that test that are not syphilis and can make it positive. So where the direct methods in this reverse sequence algorithm comes from, we can do it by ELISA type testing or chemiluminescence, but basically what both of those tests do is it tests for our body producing IgG, IgM antibodies directly to multitude of proteins that are only seen on Treponema pallidum. And so because of that, if you've ever been infected with that organism, it's going to be positive. And then if you've never been infected with it, it's going to be negative. So the pros of doing the reverse sequence algorithm is if you have long-standing syphilis, so you're in that latent stage where you no longer have symptoms, but you still harbor that bacterium, then your RPR can actually go down to very low numbers or even become non-reactive. So if you have long-standing syphilis, that test is only 66% sensitive, meaning it's going to miss 44% of cases of actual mothers that have syphilis. But if we look at the reverse sequence algorithm and we look at our first testing, in Utah, it's primarily the ELISA format that we use to test for the serologies. It's about 88% effective in the early parts of syphilis, but 100% sensitive in the later stages of syphilis. So we're going to catch all the cases of syphilis in those later stages. The problem is once it's positive, it's always positive. So even once you treat your Treponema pallidum, it's never going to go back to a non-reactive test. Where hopefully if you get mothers with primary and secondary syphilis treated appropriately, their RPRs will go back to non-reactive after about 6 months to 12 months after treatment. So then if they get reinfected, you can see then that increase in their RPR.
I appreciate that. I can see the clinical relevance of having both of those tests in most of our patients available.
I will also state the other pro of doing the reverse sequence is that test can pick up that serology 2 to 4 weeks before the RPR turns positive. So there is also this other picking it up earlier for earlier treatment.
For acute infections, you bet.
Yeah.
I have a question, and this goes back in time somewhat. Are you using the term RPR synonymously with VDRL?
Yes, they test for very similar things. Clinicians need to know, though, that for testing cerebral spinal fluid, only the VDRL is appropriate to do so.
Because that was, as I recall, the original test that was done back decades ago, and I come from those eras. And
Yes.
in fact, in those days, as I say, I ran the laboratory in 3 hospitals, and in those days, any hospital admission would routinely, part of the admission workup was VDRL that was done on everybody. And I don't know how standard or universal that is anymore. You might comment on that, and then I have some other questions that hopefully will be appropriate.
Yeah, you are absolutely correct. The RPR VDRL test that we are doing was the first described syphilis test that had any efficacy, and it's over 100 years old. So we are still using that technology. Treponema pallidum is a really tricky organism that doesn't like oxygen. It doesn't like to be out in different temperatures, so you can't grow it. It also relies on the host for many of its metabolic demands, so it makes it hard to grow in culture. So indirectly, testing for it is the only methods that we have. And you are right. When I was a resident back in the 1990s, all of our babies got tested for syphilis before they left the hospital. And when we got married in most states, our blood tests were the RPR test to make sure we didn't have syphilis. It was never an HIV test, which at that age in the 80s and 90s, HIV was, increasing in incidence. So you are correct. I think that we were so good at testing for syphilis and we got the numbers so low that by 2000, it was no longer considered cost effective to test for syphilis in any of our populations. So that when we stopped testing for it is when we allowed it to start increasing in our populations.
This might be an appropriate time to ask or make sort of an inappropriate comment. Back in those early days, the 50s and the 60s, in Utah, to obtain a marriage license, you had to have had a VDRL test.
Yes.
And I sort of always wondered, and people would ask me, what if the test is positive? Does that mean we can't get married? Do you have any comment?
Yeah, I think it was used as a mechanism to get treatment. And so, yes, you could get married, but at least it alerted the health department that at that point had a lot more resources than it currently does to do screening for you and your partner and maybe even contact tracing so that people who might have had a relationship with you could be screened and treated if necessary. So you are correct. I will say just on the state health department, they really are great advocates and they do incredibly good work. But their resources, especially after COVID, really have been decimated. And many of those contact tracers were moved over to COVID measures. And so a lot of those resources have never been returned to STI screening and testing. So even with the rise in syphilis at many of our health department clinics, they don't really have the capacity to do all STI treatment and testing. So they've prioritized pregnant women to try to get them screened and tested for STIs. And they do struggle with the workload that can occur now with even the rise in gonorrhea, chlamydia, syphilis, even, in some parts, other STIs. But truly, they don't have the capacity now to do the partner screenings like they used to do, or to do all the appointments where anybody who thought they had an STI could come into their clinic and be treated after being screened. So they really do prioritize pregnant women.
We are in Weber County, and the Weber County and Morgan County health departments are combined. And there is a rise, apparently, of syphilis in the Weber-Morgan County area. And that's one of the reasons that the health department here wanted us to speak with you and interview you about this particular topic.
Yes, and we do appreciate that. Truly, I know all of us. It's interesting that my colleagues have called me the syphilis queen, which, as everybody can imagine, maybe that's not the top or the title I want to own. It does take a team effort. So we call ourselves the Crusaders Against Syphilis. And all of us are truly trying to pick every avenue we can to educate people, because I do think there's a lot of unknowns about how you test, what the testing means, how you treat, what the treatment means. I mean, the syphilis in and of itself is the great pretender, the great imitator. It can mimic so many different things. And people think just because you have one test that's positive, one test that's negative, obviously this person couldn't have syphilis even though they come to you and they're pregnant. So obviously they're sexually active. And there's stepwise treatment algorithms and testing that you really need to go through to really work it out. And at the end, you may not know whether or not they truly have it or not, but you have to cover them because the risk of missing it is too high. versus just letting it go on to see if then they develop congenital syphilis or an RPR. We're also very concerned too that the care is spread out over multiple providers. You know, you go to your OB provider who takes care of the mom, but when she's not pregnant anymore, then she goes to her primary physician. If you're a baby born in a hospital, it may not be your pediatrician taking care of you. You have a pediatrician in the hospital that then's going to, you know, move you on to your pediatrician when you're at home. And so sometimes there's a lot of things lost in translation too. You know, if mom was suspected of having syphilis or the baby, you know, what's the rate that the RPRs are really going to be repeated as they're supposed to be, and that if they weren't treated, would they be picked up in that first year of life?
Yeah. You made a wonderful case for my specialty in family. As a family physician, I get to do both sides of that and continue to follow the patients. So,
yeah, and we do appreciate that. I also want to truly stress that my ID colleagues and I really are available. You know, that especially my pediatric infectious disease colleagues, I know they're really busy, but they are very dedicated to this topic and all infectious diseases, to where they may not call you back like right away, but they are always available. And they do want to follow these kids. They want to know about them. One of our fellows, Dr. Brett Nelson, this is what he's made his scholarly project on, is syphilis cases in Utah. What's the follow-up? What's the risk to the babies as they grow up? Because we really don't know. You know, as Dr. Johnson pointed out, many of the studies that were done is in the heyday of syphilis back in the 50s and 60s and 70s. And back then, neonatology wasn't even a field of practice. It didn't start coming in to be a dedicated field of study until the 1980s. So we're not having the same babies survive now as didn't survive then. We're able to save more babies with really severe infection. But what does that mean for their neurodevelopmental follow-up or their, you know, the health of their liver? Because syphilis really does affect the liver in utero. And that's why many babies can get high drops or die of an abortion. So I really worry that we don't know everything. And if we don't follow these kids and if we don't have the resources to make sure we know what we're dealing with, that we could miss early intervention opportunities.
great. I'd love to ask a few questions to really direct us towards that congenital syphilis. The first question that comes to mind is transmission. How transmissible is the bacteria, and is it through the placenta or is it direct inoculation at birth, or what are we looking at?
So you're correct. It can be actually any of those. If you are infected in utero, then it is usually through the placental transmission of the spirochete. The earlier you're infected, the more symptoms you're going to have, the more likelihood that you might end in a stillbirth pregnancy, because the bacterium itself is very destructive and causes a lot of inflammation. For the placenta, it causes it to be very big and boggy, and can makes its ability to transport nutrients and oxygen really reduced to a point where it can actually starve the baby of any oxygen or nutrients, also relating in a stillbirth. So the earliest you can identify and treat it, the better it is for the baby. However, if you have a mom who's shedding syphilis with primary or secondary stages of infection, then her amniotic fluid is a potential source of transmission. If she has any chancres, those are a source. So if she has one in her vagina and it's through the normal birthing canal, then that baby can be infected with that chancre. So the one thing I really need healthcare providers to know is there's a reason why we have universal precautions when we deal with patients, because you never know which patients are going to have something that they can transmit to you that you may not want to have. And syphilis is one of those. So moms that have a rash or a chancre, those sorts of things, if you handle her bodily fluid, then you are exposed and you either need treatment or you need to be followed to make sure that you don't get inoculated.
Sure. What is the, you mentioned stillbirth and maybe even fetal growth restriction. But if a child's born with congenital syphilis, and is not treated, what is that childhood like, or what happens? What are the potential complications?
Yeah, so I first want to say that the majority of kids actually look okay just by looking at them. They have no symptoms. So if you start to then press a little bit more, the workup includes a complete blood count because many times they can be thrombocytopenic or have low platelet levels. And also to do a liver panel because syphilis does affect the liver enzymes. But it can also cause these little moth-eaten appearance in the long bones of babies. And that's how we've been picking it up more often in some of our kids is by the radiologic studies. Now, it's interesting to know that those radiologic findings will actually go away on their own without any treatment. So even if the baby's not treated for its congenital syphilis, many of these things will go away. But unfortunately, then the baby starts to show more stigmata of congenital syphilis as they get older. And unfortunately, these changes do not go away when you treat. They can have changes to their bone structures. They can have what's called saber shins, where their shins are bowed. They can have a sign where their clavicles get really big and engorged because of the bone inflammation that it can cause. They can have neurodevelopmental impairments in one study estimated at up to 28% of cases. They can get little perforations in the top of their palate. They can get changes in their teeth. They can get profound acute hearing loss, which is something that they do not recover from because the organism can eat away at their middle bones and cause the deafness from the involvement of their middle ear bones. The other things, though, long-standing syphilis, it can affect the spinal column and it can reduce your myelinization. And so you can be clumsy, you can get decreased sensitivity of your extremities. And then in some instances, it can actually cause psychosis.
Okay. But I think what I heard you say is, for example, if I'm seeing a newborn in the newborn nursery on physical exam, I might not pick anything up.
Most likely you will not.
Okay. So, for example, if a mother delivered precipitously and had no prenatal care, are there any recommendations on should we be testing those babies?
Yes. If mom had, these are the moms that are most at risk. So even in the state of Utah, we know housing insecurity, methamphetamine or heroin use, or transactional sex for drugs or money, and then no prenatal care. These are the risk factors for babies that are being born with congenital syphilis. So these moms and babies need to be tested. Now you can wait for mom's test to come back before you test the baby, because sometimes, depending on when the mother got syphilis, the baby might not have increased its RPR yet. So if mom has a positive RPR and the baby does not have a positive RPR yet, it does not mean that that baby's clear from having congenital syphilis. Because if mom has acute syphilis, then by definition, that baby has syphilis as well, and they both need to be treated. The other thing I should state on the treatment algorithm that's very important is not only is syphilis reportable in all of the 50 states, you have to report it. Utah is a dual provider state to where all the labs will automatically let the State Department know that they have a positive syphilis test. But there's actually onerous on the provider to also notify the state health department that they have a patient that has syphilis. This doesn't always happen because the labs are so good, but we probably ought to know that the law states that it's a dual reporting state with the lab and the provider. The other thing that I would like to mention too is in pregnancy, if mom has early syphilis, stages primary or secondary syphilis, then the only treatment you can get is penicillin by way of a bicillin or penicillin benzathine injection. There's different types of penicillin that people need to realize because we see the confusion when we're treating the infants. The intravenous crystalline penicillin G is not the same as bicillin. The pharmacokinetics work differently. But in early syphilis, it's usually treated with just one shot of penicillin. And the reason it has to be penicillin is because of the way it crosses in the placenta. And we know that it has a direct effect on the spirochete. And the spirochete has always been highly sensitive to penicillin. So you can't use other drugs to treat it, nor can you use other drugs in a neonate. But one dose is what the CDC recommends for primary and secondary syphilis. If you have latent syphilis, then you require 3 weekly doses of bicillin. And in that regard, in pregnant women, if you don't give a weekly dose of bicillin within 7 to 9 days, you have to start over on your treatment protocol and redo it. Just like in an infant, if you're treating that infant for 10 days and you miss a dose, you have to restart the whole treatment algorithm over again. And the one thing in infants I will mention is that penicillin is really kind of noxious to IVs, just the regular peripheral IVs. And extend wells too, it can infiltrate quite easily. So for a 10-day treatment course, we make the recommendation that they probably need a PICC line for that treatment to ensure that no doses are missed and it doesn't further prolong their stay or cause tissue injury.
Is there a reason to go ahead and give a newborn that you have a high suspicion to just go ahead and give them the 1 dose of the penicillin benzathine?
Yes. So we do have an algorithm available. I'd be happy to email the algorithm that can go out to all of your listeners. But if there's a problem trying to get the baby back in for evaluation, or there's certain difficulties that we might have, like unfortunately, immigration status matters now. People are more afraid to come back and get care, or resources are limited in certain areas, then we should be giving these babies that medication on their way out the door if we don't think that they do have higher suspicions for congenital syphilis. The ones that should get penicillin leaving the door are those that are low risk, not necessarily no risk, but low risk, that you really don't think they have it. You're just trying to make sure you've done everything to protect them as they leave the hospital. But if there's a moderate risk or a high risk, they need the whole treatment course after they're evaluated. The other thing I should mention about evaluating a newborn is an LP is part of the recommendation. But I want to point out that if a kid has thrombocytopenia on their CBC, where it makes an LP risky or dangerous, knowing whether or not the kid has congenital neurologic syphilis, neurosyphilis, does not matter in the treatment course. It does not change that it's still 10 days of antibiotics for that kid, and then the RPRs are followed as they grow up. So you don't have to feel obligated to do an LP if it's unsafe. The other thing that I will mention is that if you get a bloody CSF, then you can't use that in your determination of whether or not it's neurosyphilis, because then you can't tell if it's still from the blood or from the CSF. The other thing is a VDRL, when we look at CSF sensitivity in newborns, it's only about 60% sensitive. So it's not a highly sensitive test. So we should do it when we can do it safely. That information is still very important to get, but we shouldn't make it unsafe for the kid if it's not going to change their outcome. I will say, though, that I did get a lot of support from our follow-up clinic at Primaries, our neurodevelopmental follow-up clinic, that if we do identify a baby with possible neurosyphilis, or we can't test them adequately for that, they will follow these kids in that clinic to make sure that they're developing normally, and if not, that they can give resources to the family.
Great. Val, what are you thinking now about
Well, you mentioned about penicillin and said in some effect, all penicillin is not the same. The
Yes.
treatment that you say you're recommending is bicillin, is that right?
For single injections, for the moms, that's
Yes.
what's recommended in pregnancy. For a baby that has low risk, that's recommended. Unfortunately, we've seen a couple of cases that the babies were supposed to be treated with 10 days of penicillin, and they got 3 days of the injectable, or I'm sorry, three days of the IV form of penicillin. And then on like the 4th day, they got a bicillin dose and was, discharged home. It doesn't work that way. You can't combine those modalities, because again, the reason we give continuous infusions of penicillin over those 10 days is to decrease the likelihood that penicillin is going to, make its home in some of those immune protective spots like our brain, our eyes, or our ears. So it's important not to confuse that they can overlap.
Okay, so that penicillin G, which is sort of what we consider the old time or original penicillin is not the preferred treatment. Is that correct? Bicillin is the preferred penicillin?
Well, so that is penicillin G.
Okay.
It just depends on the type of that you're giving it. The benzathine penicillin G is what the injectable form is. It has a slow release in the tissue. But then the crystalline penicillin G is what we give intravenous to keep our levels up and to get into the brain.
Okay, thank you. Yes, I was confused in my head a little bit about that. And you said that other antibiotics that many people think of as the more powerful, more recent, more up-to-date are not really the preferred antibiotic for
Correct. We don't have enough data. And if a mom says she has a penicillin allergy, she needs to go through desensitization in order to be treated with penicillin. There still is considered no alternative to pregnant women or the neonates. I will say, though, that when penicillin was in shortage, which we don't consider it in shortage anymore, but last summer when we were really having problems, the preferred drug was doxycycline. And so that is still something that the CDC recommends that you can treat. The problem is for primary and secondary syphilis, you have to give doxycycline twice a day for 14 days. If they have late stages of syphilis, it's twice a day for 28 days. And I just don't know any human that would actually complete those antibiotic courses as written, scheduled for those time periods, because doxy is one of those antibiotics that doesn't make you feel real good after a couple of days.
Okay, I will make a comment. This is one of those inappropriate ones probably, but it's one that was memorable for me going back into the 1950s and the 60s when we were told that we got syphilis from the toilet seat. And the other part of the comment was, that's a very strange place to have sex.
Yes, exactly.
Now I'll shut up.
Well, no, I think you make a great point. Syphilis, you do not get from touching different counters, sitting on a toilet. It does not survive outside the body for any length of time. But going back to people who have, primary, secondary syphilis, and they are contagious, it does take 24 hours of penicillin therapy for them not to, what we consider for them to be contagious anymore. So providers just really need to be astute to the fact that for that first 24 hours of penicillin treatment, they are still considered contagious and they should wear their gloves. But I would also we talked a little bit about the Utah numbers. I kind of like to share those because I think it really does go into the remarkable work that the Crusaders Against Syphilis are trying to accomplish, our state task force. So in 2023, we had 16 cases of congenital syphilis. Last year, we only had 13. So we actually are decreasing. What's nice is even though the maternal numbers are increasing, those safety standpoints we have with increased maternal testing during pregnancy and trying to capture it earlier, even though moms are increasing, babies are decreasing. So I think that's a really big win for the state health department and all of our efforts that we've tried to do with our OB colleagues to get a handle on this. And so we're hoping it continues to go down. So in 2023, there was 177 cases in women, about 30% of those in pregnant women. This year, we had a rise of syphilis cases in women to 204, and less of those are occurring in pregnant women, about 29%. So we really feel that our efforts are making a difference.
Great. Any thoughts about the immigrant wave of the past few years from South America, and is that affecting, or will it affect the numbers in the next few years?
I think it has already affected our numbers. We are picking up more women by the reverse sequence algorithm, which means that they probably do have long-standing syphilis, particularly because we're finding that those are probably real cases with changes on long bone films in their babies. And so this is where, you have to believe your lab test. We did write up a case report, Dr. Nelson and I, and our colleagues wrote a case report about a couple of women who probably had syphilis for the last couple of decades, but came back and they had serofast RPRs, meaning very low and stable. But then their reverse sequence algorithms were positive. The physicians taking care of the moms didn't want to believe that they had syphilis, but their baby's test showed that they actually did. And so you really have to believe these tests when they come back and treat according to the algorithms, and not think that these tests, especially the reverse sequence, are not reliable. These tests are probably more reliable than the RPR. So I would say, please follow the algorithms. And then the one other thing I should say is, if you're an immigrant, you come into the state of Utah, even from outside the country or outside the state, and you've been treated for syphilis, if your treatment is not documented by the state of Utah and you're a pregnant woman, it doesn't count. If you're treated in a different state, they just need to have record of when you were diagnosed with syphilis and what your treatment was, what was the dose, and what was the dates of those injections. If you're from outside the country, we need similar information, but we may be more likely to rescreen and retreat you. So for all pregnant women, if the state of Utah does not have treatment information, you are considered untreated in the eyes of the state, and your baby is at risk for congenital syphilis. Now, many times, and it's getting better over time, we will get moms that we have been told that she was treated for syphilis a couple of years ago, but they don't know any of the information. All that information that the state has is available 24/7 through their epidemiology line. And if I could, I'd like to give that number to your listeners, because they are truly available whenever needed. And their number is 1-888-374-8824. It's 1-888-EPI, EPI, Utah.
And you mentioned 24/7 it's available. What exactly is available there? Is there
So if, like, for us, if we get an infant from another hospital, let's say because they have symptomatic congenital syphilis at birth, but we get that record that says mom might have been treated for syphilis in the past, but there's no information, I can call that number and I can get the information that they have. What was mom's last RPR, or what was her ELISA data, positive or negative? And then when was she treated? Because then I can look at the current information I have and determine if the RPR is rising or decreasing or staying the same, and what my suspicions should be that this baby should be further worked up or screened for syphilis.
Awesome. So the state warehouses all that data, and we can access that through that number, 1-888-EPI, Utah.
Yes, they do ask, though, that during the daytime hours, you try to work with your county epidemiologist, but at night, they're always available for anybody who needs maternal information.
Very cool. Well, we appreciate your time. Are there any things that we haven't touched on that you would like to talk about?
I think at the end of the day, I mean, William Osler said it the best. I think it was him, Sir William Osler, that to know syphilis is to know medicine. And there is so much about syphilis that we do not still understand. And now that we have a lot more diagnostic capabilities and newer lab techniques, I'm hoping that we can learn more about syphilis. My problems that we're having across the nation is everybody is so compartmentalized. So we really don't have any new information about how much the reverse sequence algorithm is picking up over the RPR value, or what are these babies' long-term outcomes? What does even serofast mean? Because as we're finding out, serofast may still be that there is a little bit of a response, that you're not completely cured of your previous syphilis infection. So there's so much about syphilis that we still don't understand, that even those of us that have a lot of interest in syphilis still feel that we may not also have enough knowledge, that it's okay to call for a lifeline. It's okay to say you don't know. It's okay to try to get a consensus thought process of how you should treat those kids. for any kid in the state of Utah, the pediatric infectious disease doctors want to know about you. If you have a mom that you're worried about, you can always talk to your pediatric ID consultants, because again, I don't think we know everything that we need to know.
Wonderful. I need to ask you a few, for the podcast to round it out, a few human interest. Have you read any good books lately that you would recommend to our listeners?
I have A Walk in the Park by, why am I blanking on Kevin's last name? But two reporters that walked the rim to rim of the Grand Canyon over a year, and maybe they weren't quite prepared beforehand. And then I currently am reading this book, Ghost of Honolulu. Oh, wait a minute. There we go. The Ghost of Honolulu. Anyway, it's a book by NCIS specialist about the spy rings during World War II in Hawaii before the bombing of Pearl Harbor. So
wow,
those are my nerd books.
I thought you might be bringing something about the Molokai tuberculosis or the leper colonies there in Molokai, but
oh, you know what was a really good book was Wonder Drug, about the problems with thalidomide back in the 60s. I would recommend that book to anybody with an interest in medicine. The interesting thing that I found interesting about it is there's so many overlapping themes with the opioid crisis. Actually, the Sacklers were brought up in that book at some point. So I thought that was a very good book.
what was the title on that one?
Wonder Drug, The Rise of Thalidomide.
Thalidomide, great. Okay, wonderful. Any travel plans that you have upcoming?
I just got back from Yellowstone in winter. I would recommend that to anybody that likes the national parks off season. There's such a small group of people that go to Yellowstone in the winter time. So rather than fighting all the crowds, there's like just a couple of hundred people in the park. I got to see the Wapiti Wolf Pack 2 days in a row, all 19 members. So I can die happy. I guess I had 3 dog days where we saw coyotes, red-tailed foxes, and wolves. So I would definitely recommend people to check out Yellowstone in wintertime.
Excellent recommendations. Well, thank you very much. Val, any questions?
No, Yellowstone in winter is great. That's a good choice for you.
So beautiful. Yeah.
Thank you. This is very fun today to talk with you and to realize, that, syphilis has been around forever. And historically, you go back and it was one of the major diseases. And then in about the mid-1900s, after penicillin and so on, we began to kind of forget about it. Oh, that one's been taken care of, sort of like smallpox. And yet to now hear about it again it's kind of refreshing to know that, we did not always know everything about syphilis and other venereal diseases, and we don't know now everything about it. So
well, but the hesitancy of people to even test for it is what still boggles my mind. When we were pushing 3-point testing before ACOG did, the amount of obstetricians that told me it's not my patient. Like, I just don't understand how that's not your patient, because obviously they're sexually active and not using protection because they're pregnant. So I don't understand that thought process. And, it took years after universal HIV testing that I still see some babies not be tested for HIV, which is completely treatable, syphilis completely treatable. But when we look at hepatitis B and HIV, they infect only truly a handful of people in the US every year. But in 2022, 3,700 plus infants had syphilis. Like, only 50 or less had either HIV or hepatitis B. But more importantly, hepatitis C, which is also completely treatable. There's not universal screening for that, but there's 20,000 women, I think in 2021, that had hepatitis C that were pregnant. So I would again encourage people to test for what we can treat and test often.
Sure. It can be such a silent infection too in women. I mean, they oftentimes, I don't know the numbers, but I would say many have no idea that they are infected. So,
Yeah, the other thing for any emergency room doctors that are out there, your emergency room might be the point of contact for pregnant women. And so you should consider sending an STI panel on those women that are seen in the emergency department to make sure that we don't miss any screening of women ever.
we didn't touch on the Jerish-Hexheimer reaction, but maybe
Yes.
in your talk when you come up, is there any danger for a pregnant woman?
There can be. It's incredibly rare that if mom does have a history of anaphylaxis and she's in a secondary stage of syphilis, she needs to be admitted to the hospital when she gets her first doses of penicillin to make sure that she doesn't need to be desensitized and that she's not going to have that reaction. We can talk about it during my conference up there. But basically what causes that reaction is this profound killing of Treponema pallidum that causes almost like a cytokine storm effect in mom and can cause her to go almost into septic shock, or at least this just profound immune response. And so those things need to be monitored in some women, but we shouldn't be afraid to give all women who say they have penicillin allergy penicillin, because many of them didn't really have a true anaphylactic reaction to penicillin.
Wonderful. We are so excited that you're coming up here in May. You'll reach an audience of several hundred physicians and other clinicians, and your crusade, which is having a great effect, will just carry on. So we are very excited to have you come to our meetings.
Oh, I'm super excited to come. And it's been a pleasure too to be able to get the word out on the podcast. So any opportunities I have, we looked for all of them.
Thank you kindly, Dr. Lawrence.
Thank you.
Thank you.
Thank you for listening to our podcast. This episode was produced by Clark Madsen, Teresa Paskedra, and the board of the Ogden Surgical Medical Society. Our executive director is Teresa Paskedra. Editing and sound design were provided by Eli Whittier with the support of the members of the Ogden Surgical Medical Society. Thanks again for joining us, and we'll see you next time.